and management I will cover on next year.
Okay.
So these are the questions which are asked previously. So starting from screening and total PSA, PSA related questions couple of times, risk-based approach to organ confined CA prostate, management of CRPC, robotic versus lap surgery for CA prostate with evidence, and robot-assisted radical prostatectomy. These are the questions which are asked in previous papers. So to start with, it is most common cancer in men worldwide. 1 out of 8 men will develop cancer in their lifetime. In India, it is 12th most common according to Globocon 2020. So basically, prostate carcinoma is indolent in nature with long natural history, but occasionally it can be a lethal. It is second most common cause of death from cancer in the US, while in India it is 14th most common cancer. So to start with risk factors, age is one of the most commonly related to the risk factors, which is increasing age is associated with a risk of occurring prostate cancer. Family history, the relative risk increase with positive family history. If father is associated with prostate cancer, it increases with more than 2 times. Brother is associated with prostate cancer, then the risk is increased by 3 times. And if more than 2 first degree relatives are associated with prostate cancer, then the relative risk increased by more than 4 times. So there are some germline mutations which are involved in DNA repair mechanism, which are BRCA1-2, ATM, CHEK2, OXB13, and Lynch syndrome. Out of this, BRCA2 is most common, which is associated up to 44% of the prostate cancers. Chronic inflammation is another risk factor, which is associated with cellular injury from genotoxic stress. And for that, some studies are also conducted to try NSAIDs to reduce the risk of prostate cancers, but they are ultimately non-conclusive. So obesity is not direct a risk factor, but it is associated with morbidity associated to the prostate cancer and increased risk of occurring cancer with high grade and higher stage. So there is one trial, PLCO trial, which states that high BMI is associated with high prostate cancer mortality. So in diet,
प्रोस्टेट
the
लंग
diet which
कोलोन एंड पीएलसीओ फुल फॉर्म क्या है यार? हेलो,
hello,
पीएलसीओ फुल फॉर्म पूछ रहा है.
PLCO prostate lung colon and ovary.
Continue.
Yeah. So in diet, fried food, overcooked red meat, trans fatty acids associated with increasing risk. Then lycopene, which is more common in tomatoes, which is antioxidant, reduces lethal prostate cancer by 30%. So race is another strong risk factor where African American has more than 1.5 times risk of diagnosing and dying of cancer. So lifestyles which are also associated with obesity and which are all modifying risk factors, they are not directly related to the prostate cancer, but it is same as obesity where it decreases the risk of dying. So next is a prevention. So for the prevention purpose, there are 2 trials which are conducted, PCPT trial and REDUCE trial. So PCPT is prostate cancer prevention trial, which were conducted for over more than 18,000 persons, where finasteride versus placebo is tried for 7 years, and all patients or all persons in trials were biopsied if they are found to be PSA more than 4, abnormal DRE examination, and at the end of study, irrespective of all these indication. So they found that overall there is no benefit of overall survivor, and there is another reduced trial, the reduction by dutasteride of prostate cancer events. they have also found the same result at PCPT. So ultimately, there is no preventive approach for the prostate cancer. So to summarize the histology, the normal prostate is made up of lobules of secretory acinar epithelial cells surrounded by supporting basal cells within fibromuscular stroma. So there is one PIN that is precursor intraepithelial neoplasia, which is associated with synchronous and metachronous prostate cancers, divided into three groups: low grade, which includes PIN1, and high grade, which is included PIN2 and 3. The high grade is associated with increasing risk of prostate cancer in the short-term duration. So histological types, there are most commonly more than 95% acinar adenosia is common. In less than 5%, it is ductal adenosia. In less than 1%, other histological subtypes like neuroendocrine tumor or small cell carcinomas are there. So there is one another entity, IDCP, which is intraductal carcinoma prostate, which is aggressive form with high-grade tumor spreading non-invasively to prostatic ducts and acini. In contrast to PIN, which is intraductal, which is associated with neoplastic intraductal proliferation, IDCP has atypical pleomorphic cells with cribriform growth and comedonecrosis. So IDCP histology is associated with poor outcome even after surgery or radical RT. So in prostate cancer, the hallmark of prostate cancer, which separates from the PIN, is lack of basal cells. And in histological grading, the Gleason's grading is what we commonly use, and which is associated one of the most significant factor for the prognostication of the prostate cancer. First described by Dr. Donald Gleason in 1966, and later on modified for the better prognostication. So it is based on architectural pattern and intratumoral morphological heterogeneity. There are three groups: pattern 3, 4, and 5. So it is just like a well differentiated, moderately differentiated, and poorly differentiated, but defined differently. So pattern 3 has well-formed glands. Pattern 4 has poorly formed fused cribriform glands. Pattern 5 has single cell sheets and very poorly differentiated glands with necrosis and solidness. So based on these patterns, ISUP is divided grade groups for the prognostication, and 5 grade groups are there. So the scoring is based on the highest and second highest predominant pattern of the histology. So only two difference to remember here is Gleason's grade 2 and 3, where both has score 7, but it separates itself from the predominant grade pattern. So in grade group 2, the predominant group is pattern 3, and in grade 3, the predominant pattern is pattern 4. So there is another terminology in DVITA which states itself a digital pathology, which is AI-based product, which is basically it is a software digital imaging analysis tool which analyzes MRI imaging, which has high negative predictive value. And one of the software which is FDA approved is Page Prostate Digital Imaging Analysis Software. So in molecular pathology, I will not go into detail, but there are a couple of gene and molecular things we should know. One is the ETS gene fusion, which is found in 40 to 50% of all tumors, which is second most common molecular alteration in gene rearrangement in ETS family of transcription factors. So there are one in ETS gene fusion, most common is TMPRSS2 gene, which is found in 30 to 40% of all, and this is the gene fusion we use in urine markers to screen the patient for the prostate cancer. This is associated with high EPE, extra prostatic extension, with no difference in outcome. Another one is the PI3K, AKT, and mTOR pathway alteration, which are significant in a way that there are potential therapeutic targets to develop in a near future. Another is WNT pathway alteration, which is associated with androgen-independent tumor growth and suggests treatment resistance to anti-androgen. So this will in future will tell whether the patient will develop a CRPC tumor or not. Another is long non-coding RNAs, which is LNC RNAs, which are also very in high sensitivity and specificity in urine level, associated with the likelihood of cancer for patient with prior negative biopsy. So screening is another questions which was asked in exam. So there are two major trials which were conducted for screening. One is PLCO trial and another is ERSPC trial. So PLCO is ultimately concluded there is no difference in cancer-specific mortality, though it has benefited in increasing diagnosing of the number of cancers. ERSPC trial concluded it reduces in high-grade locally advanced metastatic cancer detection and 21% reduction in cancer-specific mortality. But it has some negative factors, such as to prevent one death, they have to screen 781 men continuously for 13 years, and 27 out of those 781 has to be diagnosed with cancers. So overall, it leads to overdiagnosis and overtreatment with little to no benefits to the overall survival, as average age of diagnosis is already 66 years. So in prostate cancer, the key issue is to identify potentially aggressive and clinically significant or harmful disease, and not to identify more cases. So what is clinically significant? It is Gleason's score more than or equal to 7, which is clinically significant. So there are a number of guideline bodies which which provide guidelines for the screening of the men for the prostate cancer. One is USPSTF, which states is a grade C, and PSA-based screening to be done between 55 to 69 years, and it should be a shared decision, and it is not recommended for men with 17 or more than 70 years of age. AUA is also states same, 55 to 69, not recommended for more than 70. NCCN is also like same. PSA-based screening should start at 45 years with frequency between 1 to 4 years, depending on the baseline PSA level. EUA also states risk-based approach. It should start early for the men with high risk for the prostate cancer, as early as 40 with BRCA mutated person, and it at 45 years with African descent family history of prostate cancer, and at the age of 50 for all. The interval they state that it has to be 2 years for PSA more than 1, and if it is more than 2, it's 6. So there are another two trials which conducted, with its pivot trial, ERSPC trial, which states that if life expectancy is less than 15 years, the person would not benefit from the screening. So screening should not be done in person with life expectancy less than 15 years. So ultimately, consensus guideline states the screening should be opportunistic, where men who present for routine health examination should be made aware of PSA screening and their benefit, and shared decision to be made. And it should be started at the age of 45. If PSA is less than 1, it must be repeated at the interval of 2 to 4 years. If PSA is 1 to 3, the interval should be shorter, 1 to 2 years. And if PSA is more than 3, the further investigation in the form of MRI or early repeat of the PSA should be advised. High risk factors, which includes African ancestry, known germline mutation, strong family history, should begin screening at early at the age of 40. And men with more than 75 years or life expectancy less than 10 years should not be screened. This is the final consensus guideline. So for the screening purpose, there are three modalities: blood, urine, and imaging. For the blood, PSA derivatives, and there are some indexes and score which are based on these PSA derivatives which are used. For the urine, there is PCA3 and TMPRSS2 gene fusion. And for imaging purpose, MRI is used. So let's start with PSA. PSA is also known as human kallikrein 3, produced by prostatic luminal epithelial cells, hence present in both benign and malignant conditions. In circulation, it exists in two forms, free and bound form. Majority is bound form, more than 75%. It has half-life of 2 to 3 days, and we usually consider a DRE, digital rectal examination, increase the PSA level, but it does not increase a significant level where it alters the management of our patient on the PSA. Other benign condition which increases PSA is infection, catheterization, urinary retention, or trauma in the form of biopsy or ejaculation, which increases the PSA. So there are three PSA derivatives which are more commonly or routinely practiced. First is PSA density. So the PSA density is PSA divided by the total prostate volume. Usually it is less than 0.08. Person with 0.09 has 4% chance of harboring clinically significant disease, which is Gleason score more than or equal to 7. And this is one recently added to EUA guidelines for one of the key factor to suggest for a prostate biopsy. Another is a ratio of free PSA to total PSA, which decrease in cancer. Free PSA has greatest value in PSA level between 4 to 10. And if free PSA has less than or equal to 25%, then it has 95% sensitivity and 20% specificity for the cancer detection. Free PSA suggests aggressive pathology and is associated with poor outcome. So another is PSA velocity, which was previously routinely used but has little diagnosing value, and it suggests aggressive disease. So another isoforms, another derivatives of PSA isoforms. There are three isoforms: pro PSA, intact PSA, and benign PSA. Out of these three, pro PSA has three another isoforms: 2, 5, and 7 pro PSA. They all showed some correlation with cancer, but not proven or not clinically used. And there are two more FDA approved indexes or scores. One is PHI, Prostate Health Index, which is developed by Beckman Coulter, based on 2 pro PSA, free PSA, and total PSA. So they are more useful for patients with PSA between 2 to 10, and they outperform free PSA and total PSA for cancer detection. And they also suggest more significantly for the clinically significant prostate cancers. So another is 4K score, which is developed by Opco Labs, based on total PSA, free PSA, HK2, which is active form of PSA, free PSA cleavage products, patient's age, and prostate biopsy history. They predict a clinically significant prostate carcinoma and eliminate need for biopsy in low risk group without missing aggressive disease. So next is urine-based markers. So there are two markers which are routinely used. One is PCA3, which is also called Progensa, which is FDA approved. It is long non-coding RNA exclusively found in prostate with strong predilection for cancer. So what to do for PCA3 testing? So after prostatic massage, initial urine is collected for testing. So at the level of 25, the sensitivity is 74% and specificity is 57%. So current indication is men with prior negative biopsy with persistent suspicion of disease and high risk of biopsy new men delaying for biopsy. So only two patients will benefit. One is prior negative biopsy with persistent high risk, and high risk person who is delaying for the biopsy. Another is TM, TMPRSS2 June fusion, which is also called as my prostate score. So June fusion between 5 end of the transmembrane protease serine 2 with ERG, which is ETS related genes. So it occurs in almost 50% of the all prostate cancers. The another couple of things which urine-based markers are there, but they are not FDA approved or routinely used are OXY6, DLX1 mRNA, which is also called as Select MDX, and the last one is Prostarix, which is metabolites to sarcosine. So the last is the imaging method for the screening, which is MRI. So there are two studies, IP1 prostagram and the re-imaging. So IP1 prostagram is combination of PSA with MRI for the decision of biopsy. So they concluded that PSA more than or equal to 1 with MRI pyrad score of more than or equal to 4 will maintain detection rate of Gleason's grade group more than 2 while decreasing the number of men needed for biopsy. So they confirm the role of MRI in screening and adding their role in decision making for the biopsy. Another one is re-imaging study, which is ongoing study. Results are not yet out, and they are considering feasibility of only MRI for the prostate screening and decision making for the biopsy. So IP1 included PSA also to screening with MRI, but re-imaging is only included MRI for the screening. As we all know, there is MRI grading for the prostate screening, which is PIRADS 1 to 5. 1 states very low, increasing the risk of prostate cancer, and 5 is very high. So in a patient where clinical suspicious of prostate carcinoma is there, the first test to order is PSA. And normal value of PSA varies depending on the age, which is as low as 2.5 and as high as 6.5 in a man aged 70 to 79. So our institutional protocol is if first PSA is high, we repeat it after 6 to 8 weeks, and if it is still high, we go for further investigation. So if PSA is persistently high, MRI is the first imaging we do, and it should be done even before the biopsy, as it guide us for the specific site for the considering for the biopsy. So indications for biopsy, there are 3 indications. First is the biopsy new man, the first initial biopsy. Second is repeat biopsy, and third is patient on active surveillance who require repeat biopsy. So the patient with raised PSA with risk factor, suspicion on clinical digital rectal examination, symptoms suggestive of prostate cancer or symptoms suggestive of metastatic disease in the form of wound lesions or retroperitoneal or pelvic lymphadenopathies. In a repeat cases where patient initially went for biopsy has very low risk in a risk stratification, or a patient on initial biopsy is showing small acinar proliferation only without any significant PIN. Those patients we will keep on follow-up, and in follow-up, if they are having rising or persistently elevated PSA with extensive PIN, positive urinary markers, or in imaging the lesion, a new lesion is appearing, or the lesion is increasing in size, or the lesion becoming more suspicious, then the repeat biopsy is indicated. The only contraindications for prostatic biopsy is significant coagulopathy, severe immunosuppression, or acute prostatitis. This is the table which I have included from the EUA guidelines, which is recently added, not in the previous editions. So the pre-assay density is what all they have included in addition of the PIRAD scoring of the MRI imaging to provide indication for the prostate biopsy. So ultimately, PIRATS 4 and 5, all patients must go for biopsy. In PIRATS 1 and 2, if PSA density is more than or equal to 0.20, then we should consider for biopsy. In PIRATS 3, if the PSA density is more than 0.10, then only we should consider for biopsy. Rest all case we can avoid the biopsy, because in all other cases the chances of finding clinical suspicious prostate cancer is very low. So this was the question asked in previous exam, which is a risk-based pathway for the prostate cancer screening, which is also given in the data, and somehow it is also associated with this EUA-based screening protocol provided in the guidelines. So it states that men with suspected prostate cancer should go for MRI. Based on the MRI PIRATE scoring, they have divided the patients with high risk features and without high risk features. So what they concluded for the high risk feature is PSA density more than 0.15, suspicious or digital rectal examination, family history, and patient on active surveillance. If a patient with PIRATS 1, 2, 3 are associated with one of these high risk, they should go for biopsy. And if they are not associated with these high risk features, they can avoid the biopsy. And all PIRATS 4 and 5 should go for biopsy. So there are three modalities for prostatic biopsy: transrectal, transperineal, and transurethral. So most commonly is transrectal is practiced. So what are the benefits and disadvantages of transperineal approach? So it is used only in a patients with lack of rectum where congenital anomaly, or surgically removed patients where rectum is not there. We go for transperineal approach. It reduces infection rates, better for apical tumors, but it needs extensive anesthesia and inferior visualization of the other lobes of prostate. The transurethral approach, which very early stage was used, but now TRUS is most commonly and better approach is used. So in TRUS, there are 4 methods to go for a biopsy. The first is the sextant biopsy, which is 6-core biopsy. The second one is the 10-core biopsy. Third one is the 12-core biopsy, which is double sextant, which is currently most commonly recommended by all the guidelines, and all our institutional practice is also 12-core biopsy. And the fourth one is the 13-core 5-region biopsy. So the double sextant or the 12-core biopsy includes 2 biopsy from the base, middle, and apex from the each side, plus additional core biopsy from the suspected areas. So to work for the staging workup, it is basically depend upon the primary extent of the disease, Gleason's grade group, and PSA of the patient. So our institutional practice is if patient is localized disease, in the risk stratification, if it is intermediate unfavorable group, high or very high risk group, then we go for the metastatic workup. If it comes in a loco-regional disease where extra prostatic extension is there, or loco-regionally lymph nodes are involved in primary investigation, then we go for a metastatic workup. Patient has symptoms of metastasis, PSA more than 20, and in histology of biopsy, if Gleason's score is more than or equal to 8, then we go for metastatic workup. So for staging purpose, for T-stage, multiparametric MRI is gold standard. It is including T2 weighted images, diffusion weighted images, and dynamic contrast enhancing imaging. These 3 modalities are compiled for the MP-MRI, which is more specifically detecting the extra prostatic extension and seminal vesicle invasion. For the end stage, Overall, PSMA PET scan is more sensitive and specific, combining both MRI and CT. But in our practice, if it is locally confined disease and not the other patient is not suitable for the metastatic workup, we do it only from the MRI itself. And for the metastatic workup, PSMA PET scan is gold standard. Why PSMA not FDG? Because PSMA is transmembrane glycoprotein. Its expression is remain high even in the dedifferentiated, metastatic, and hormone refractory cancers. Why FDG is not used in prostate? Because it is low glucose utilizing cancer, urinary excretion, mask uptake in prostate, and non-malignant conditions such as BPH, prostatitis, or any cystic malformation also takes uptake of FDG. So PSMA PET is gold standard for the metastatic workup. For the risk stratification, there are many risk stratification are there, but out of those, AJCC and StarCap is what most commonly used. StarCap is first and the only prognostic system that meets all criteria suitable to serve as a valid staging system and outperforms all others. So StarCap is staging collaboration for cancer of the prostate, which is aimed as per the AJCC risk stratification system and meet all 14 criteria. It includes age, clinical T stage, clinical N stage, primary and secondary Gleason score, number of positive cores, number of negative cores, and PSA value. It provides stage and 5 and 10-year cancer-specific mortality to the patient. There are 3 molecular risk stratifications are there. Decipher is a 22 gene biomarker, predict development of distant metastasis. Another is Oncotype DX GPS, which is genomic prostate score, is a 17 gene signature that runs in a real RT-PCR platform and provides pre-treatment. It is done on the pre-treatment biopsy samples. Another is Polaris, which is comprised of the cell cycle progression score with the Capra clinical model, and which is not proven yet. Another is EAU model, which is not commonly used, but it comprises low risk, intermediate risk, and high risk group, which is basically PSA, Gleason score, and T staging are included in the risk stratification. This is the AJCC or NCCN risk stratification, which is most widely and most commonly used. It divides patient with localized disease only based on the T staging Gleason. Modalities, the percentage of biopsy which is positive for the cancer, PSA and PSA density. So to remember, a very low group includes only patients which are diagnosed with basically a prostate biopsy, not a TRUS or any suspicious identification of lesion, which includes lesions grade 1, PSA less than 10, fewer than 3 prostate biopsy fragments, or less than 50% cancer in each fragment, and PSA density less than 0.50. Here the demarcation lies in the intermediate group, where favorable and unfavorable risk group are further subcategorically divided. Because for the metastatic workup also, according to the NCCN, if a patient falls in the unfavorable intermediate risk category, then they all must go to a metastatic workup. And if it comes to the favorable intermediate low or very low, then metastatic workup is not required. So it is basically all to remember. So I will not read all the subcategories and all the factors, but I will share the PPT in the group, and better to read and remember. So the last is the staging, TNM staging. The T stage is T1 is only those patients where clinically or radiologically there is no detectable lesion in the prostate, where 1A is post TURP less than 5% of the tissue is with cancer. T1B is more than 5% post TURP with cancer. T1C is not TURP, but it is just a needle biopsy. T2 is confined to the prostate. So to remember T2, just imagine a round shaped balloon and divide it into the 4 equal quadrant, and 2A, 2B and 2C. 2A is less than one half of the one side, 2B is more than one half of the one side, and 2 is involved the both sides. T3 is outside the prostate, extra prostatic extension, and only one organ which is included in extra prostatic extension is the seminal vesicles. So 3A is extra prostatic extension with capsule breach. T3B is invasion of the seminal vesicles. All other organ involvement out of the seminal vesicles are T4. N0, N1 and M1 is all that as normal. So this is all what I have to present today. I am preparing for the management and all the detail for the each strategies, and after concluding each strategies, I have make it a single page management for the each stage group. So this is all what I have to present for today.
Thank you.
Thank you, guys.
Nice presentation. How many Euro cases people are assisting?
In our institute, there is organ specific practice. So usually in a month, at least 10 to 15 cases.
So your Euro posting is over or
While in rotation, yeah.
over?
Almost over. My last posting is in this month.
Okay. You have done anything, or what all cases you have seen in Euro?
नहीं यूरो में प्रोस्टेट का सब देखा है, मतलब ऑल रोबोटिक लेप्रोस्कोपिक सब. ब्लैडर में नियो ब्लैडर, डाइवर्जन, रेडिकल प्रोस्टेट, किडनी में भी पार्शियल नेफ्रेक्टोमी सब करते हैं.
Okay. And laparoscopic and robotic both.
हाँ, लेप्रोस्कोपी और रोबोटिक तो यस.
ग्रेट यार. व्हाट अबाउट जीआई? जीआई में क्या क्या कर देखते हो?
जीआई में थोड़ा कम है, बिकॉज इतना केस लोड है ही नहीं. सो वेरी लेस नंबर ऑफ जीआई केसेस. बेसिकली बॉवेल्स में, मतलब कोलोन, रेक्टम, वो सब ज्यादा है, उसमें भी एचपीबी का बहुत कम है.
New people, introduce yourself please.
कौन है न्यू?